Hi friends, good evening. I'm Dr. Ashutosh Gupta, and many a times this is a very common and a pertinent questions being asked by everyone. As a matter of fact, why these ultrasounds are important, right? And why do we need to do these ultrasounds that frequent into the baby when I'm a low risk, when I don't have any issues in the family, and all those stuff, right? So meaning thereby just to put all those things into the right perspective, 4 to 5%, meaning thereby 4 to 5 out of 100 fetuses, they can have some issues or the other. And meaning thereby that they could be that critical in which meaning thereby that the medical or the surgical management of that particular sort of an anomaly or a sort of an abnormality that we are picking up on an ultrasound would need a lot of effort, right? And then the prognosis might even not be that great, right? So therefore the ultrasound is being required at a designated gestational age, so as to identify, so as to pick them up early and just to let them know uh, what they want to do with that pregnancy, right? Okay, so meaning thereby that the counseling after that abnormality is very very important, right? First, secondly, what if the level 2 is all normal, then also can we rule out absolutely everything to the baby? The answer is no. In my own experience, we have come across with a lot of abnormalities that probably they were not there at the anomaly scan or at 19-week scan or 20-week scan, right? And they could be sort of an in that course of duration of 20 weeks, after 20 weeks of gestation, we can have some infection and therefore we can have a ventriculomegaly and therefore it resolves definitely. We can have some issues with the gut and therefore we can have an ileoatresia, or probably we can have an evolving Hirschsprung's disease. We really don't have any hunch and any idea in less than 19 weeks, right? And then we can have we can have Milroy's disease, which is a localized lymphedema of the feet. I do have those cases, and so meaning thereby that depending upon from the limb isolated to a sort of an chylosositis to any abnormality with the gut, whether it is a small or a large, or probably we can have some issues with the brain. So we can have multiple issues with the pregnancies. It also depends upon your sort of an demographic profile. It also depends upon your sort of an you belong to a high risk or a low risk group, right? So today we are going to talk about one common congenital heart disease that was being picked up at 18 weeks. So probably we'll just make you, I'll make you see the video and then probably we'll talk about it. So this is the 18-week scan, and this is the four-chamber view. We are having a very dense two ecogenic cardiac focus in the RV, but try to focus on the right ventricle. The right ventricle seems to be enlarged vis-a-vis with the LV. So LV, left ventricle, is very crescent, right? And we hardly could see any blood flow across the mitral valve. Okay, so this turns out to be very diminutive LV, no flow across the mitral valve. Then probably we are going into the three-vessel view, and then we try to look around and try to see the aortic valve and the arch of aorta, which we identify there are none. So this could be an HLHS. So the left ventricle is diminutive in size, and we are not able to see any flow which is passing through the mitral valve, and therefore that could be the reason that probably we are seeing that the left ventricle to be very atretic. And similarly, if there is no flow, there would not be an outflow. So probably we are also having an aortic atresia. So the primary diagnosis is an hypoplastic left heart syndrome, and with both the MAA, which is mitral atresia and aortic atresia, and therefore we hardly could see any flow across the mitral valve into the left ventricle, and then the blood was reversing through the arch of aorta, through the ductal arch into the arch of aorta, and therefore the pulmonary trunk was seen dilated. We can have definitely for the defunctioning of the LV, we would have any VSDs. We can have some. So we were having some apical ventricular defects. So ventricular defects they can be identified, but then these are not the primary diagnosis. The primary diagnosis is the hypoplastic left heart syndrome. We can have an associated because then the left ventricle has to defunction into the has to empty it whatever the flow is there into the right ventricle, and therefore we can have some VSDs, and therefore we can have those thick ecogenic cardiac focus into the right ventricle. Primarily, the diagnosis is hypoplastic left heart syndrome. Now, meaning thereby that 18 weeks becomes sort of an pertinent and very, very important landmark as far as the ultrasound is concerned, so as to identify this hypoplastic left heart, right? So, for all practical purposes, don't need any follow-up ultrasound so as to make this diagnosis. So HLHS can be a sort of a difficult issue, difficult sort of a clinical situation to handle, and we can have some sort of fatalities happening in utero also. After the baby is born, the baby might need some sort of a sequential cardiac surgeries, right? And so there are few things to talk about, and then definitely it could be associated with some chromosomal abnormalities. So probably before going further ahead, we might need to do some invasive stuff so as to rule out if their chromosomes are all good and absolutely the genetic makeup of the baby is absolutely great, right? So the ultrasound at any particular point, nobody is a low risk, nobody is a high risk. Every pregnancy is a high risk woman. Why on earth would a pregnant woman would come up front and she would tell me that probably this is all my history and all those stuff. So meaning thereby that we are not living in those era in which the patients would be forthcoming with those personal histories as a matter of fact. Okay, so whatever we are seeing at hand makes them the high risk or the low risk, right? Okay, so this can happen at 26 years. This might not even happen at 42, right? So meaning thereby that triaging by the maternal age was a long gone theory when these ultrasounds were not available, these techniques were not available, and therefore the consultants were also very limited, and therefore just to triage and just to have the optimal utilization of those resources, therefore we had triaged. Now every pregnancy is a high risk pregnancy. Every pregnancy passes through that risk. So meaning thereby that the pregnancy needs to be subjected through those 4 5 ultrasounds, which are very very pertinent, and definitely the fetal medicine specialists are there to solve all those mysteries of the sort of congenital abnormalities as a matter of fact. Okay, so this is an HLHS, my dear friends, and then there are a lot of things to talk about, right? It is not that easy to make a diagnosis. There are a lot of things to talk about, and therefore that might need one session and two sessions or three sessions of counseling to the parents, and to make them understand what exactly that we are dealing up with, and how do we intend to get away with all these things, right? Thank you very much for your patience.